This echo.
Let me see. Just remove the clip. Just unbutton user. Q.
Okay, so during these years, I focused on my implant supported prosthesis. I have done many cases, and I made a lot of mistakes, and I tried to correct and help and to solve all the problems. I learned from the mistake for each cases little by little, and there's no ending to learn, especially in this era of digital dentistry. So we need to stay hungry, stay curious, and stay courage to challenge the coming dental revolution. So this section I will divide into 6 parts to understand the implant-supported prosthetics, including the evolution and history of the tilt implant, and how we evaluate the patient, what data do we need, and what prosthodontists need to be concerned. And next part is the clinical procedures, the traditional technique to fabricate the immediate denture and final denture protocols. And next part is the prosthetic part. There are many materials and the different design for the definitive prosthesis. And last one is usually cause the dentist headache, the complications. Complications can classify as surgical part and prosthetic part, including the denture fracture, including the screw loosening or fracture. We will discuss how the complications develop and how to deal with them once they occur. Before 1980s, conventional removable denture is the only treatment for edentulous patients. But during 1980s to early 2000s, lots of dental implant studies were published and used in clinical patients. So people increase the quality of life with the implant helps. Large improvement in the aesthetic and fixed type is possible. So in the past, the people like removable denture with some advantage, including its cost is cheap and it's provide the lip support and it's easy to clean for some elder people. But people also suffer from the disadvantage of the removable dentures because it's uncomfortable to use. And sometimes we have the sore spot may happen and denture require relying often. And even the speech difficulty and poor retention is always complained by patients, especially in upper dentures, because the full coverage palatal plate may influence the tongue position, speaking position, and less function due to the poor retention. And implant attached overdenture. So after implant development at 1980s, overdenture is introduced. So people get benefit of implant and increased denture retention, like trim function and quality of life. It also can provide the lip support, but it's also a removable one. So it's easy to clean. So implant overdenture is the first treatment option for edentulous patient in the United States and Taiwan. But the disadvantage is similar to the removable dentures because the denture design should be the same. The maximum coverage of the denture base to improve the support, to improve the stability. And implant as anchorage provide only retentions. And the attachment should be changed every year to maintain the function. So nowadays, people don't like the removable denture, the removable treatment plan. Thus, implant supported is suggested for edentulous or partial edentulous patients. We convert the denture into the fixed type. It's totally new concept and experience for denture-wearing patients. Large improvement for trim function. We also could reduce the prosthetic size and it feel much comfortable like natural teeth. And why the implant can provide both retention and support? Because we increase the implant's number, so which means it's much expensive and surgical risk. It's not suitable for those people who concern the financial or unhealthy conditions. And then the next is tilt implant. Why we need to discuss the teeth implant? Because the teeth implants provide a lot of benefit for full mouth implant rehabilitations. Teeth implant suffered ideas create a new aspect of treatment plan. In addition, teeth implant has developed more than 20 years, so it's reliable. The using of teeth implant has a long story. One of the first cases was published in the 2000s. Although the case is unexpected consequence, the loaded implant were scheduled to be removed. They were supposed to be sacrificed after provisionalization, but the surgeon found that the immediate load teeth implant had integrated well. The benefit of teeth implant including increase the implant length and increase the primary stability and reduce the cantilever. For the increased implant length, which means it also increase the osseointegration surface. And we get the better primary stability because teeth implant has the ability to potentially anchor in multiple bicortical bone layers, like zygoma implants. And teeth implant can reduce the cantilever force via distal placement and improve the distribution of or growth of the arch. Even though patients get benefit from the teeth implant, but however, it should be placed carefully in both maxilla and mandible. Avoid the rupture, the maxillary sinus, or tearing the mandibular nerve by these two light implant positions. The best bone quality for placing is D1 bone and D2 bone. D1 bone is commonly found in the anterior mandible, and D2 bone is commonly found in the anterior maxilla and throughout whole the mandibles. And there's also some limitations of teeth implants. Ideally, the angulation should not exceed 30 degrees because bite and occlusal force may higher when the angulation is increased. And spring teeth implant is preferable to use for cantilever restorations. And the textbooks show the old school teeth implant placement, and you can have a look here. We classify as like M or V4 configuration. The M pattern is best employed in patients with available bone in the maxilla. The V4 pattern also used for patients whose maxilla has advanced bone resorption. Okay, so a successful outcome requires implants to remain immobile during healing phase. Many factors affect the success of immediate loading, include primary stability. It's also affected by implant pitch. The deep pitch is preferable. Torque should exceed 45 Newton centimeters during implant insertion. And patient's cooperation is about the oral hygiene. We take good care of oral hygiene, increase the success. And last one is prosthetic part. The prosthetic should be rigid and it should be cross-arch stability. And the fit is passive and better with minimum cantilever and bend. Okay, so next is the evaluation. So when patients missing their teeth, they suffer from aesthetic to function and often feel like embarrassed and lost his confidence. So evaluation should start from the psychosocial condition, underlying disease to the extra to intraoral status, especially in the elder patients. We need to communicate with them more, know the patient's needs, know her condition well, and we can avoid the medical disputes in the future. Evaluate should include from medical history, dental history, extra and intraoral examination, even the radiographic analysis. I think dentists are familiar to those procedures. So here I want to focus on one thing when we evaluate the patient, which is expectation. Patient's expectation is very important. It's crucial to decide the treatment plan. The patients aged from mid-50 to mid-80s, they all have different expectations to their teeth. So it's important to be as explicit as possible from the beginning. For example, we can explain and image that the natural teeth provide like 100% function, but denture provides only like 10 to 30%. So do you like your dentures to be? Dr. Mish classified the denture movement, or we call here prosthetic movement, from like PM0 to PM6, which PM0 means there's no movement in our dentures, so it's a totally fixed type. And the PM2 is a hinge movement. PM3 is hinge and apical motion. PM4 is 4 direction. PM6 is 6 directions. So for example, here's the PM6. So PM6 present in locator attachment over denture, which provide the denture in 6 directions. And we use the 2 implants to retain the dentures. And what is PM0 is no movement. So when we increase the implant numbers, the movement decreased. For example, like we put like at least like 4 implants, and it could provide a fixed type. So there's no movement in our dentures. So what does patient expect? Another evaluating including the anterior bone and the posterior ridge condition and arch form and the cost. For the anterior bone, we should check if the bone is abundant or atrophy. And posterior ridge is ideally or it's poor ridge. That's what we consider to use the tilt implant. The next one is the arch form. It's maybe a square type, taper type, or arcuate type. And we don't like the square type because it's shortest anterior posterior spread. So it can reduce our prosthetic cantilevers. And last is cost. And cost means nothing, but it also means everything. When we start to design a good treatment plan for patient, there are many things we need to consider as well. Like first, the case classification. Different cases require a different preoperative approach. For example, maxilla requires the surgical avoidance of sinus, and mandible requires avoidance of alveolar nerve. Next is measurement. The measurement must be met, the distance to the bone, we also known as inter-arch space. And smile line, decline, we also should be measured. And next is bone volume and density. And last one is the model analysis. To determine how much bone we plan to remove, or how much bone we plan to gain, and decide the final prosthetic type. Okay, about the measurement. When we decide to plan the treatment and prosthetic type, I always think about what he or she lost. He lost only teeth, or he lost even the ridge. So do my prosthetics restore only her teeth, or I replace the teeth and ridge? For me, that's the key for making the decision. Does he or she need artificial ridge or gum to support his lip? And what about his nasolabial angle? Is it in a good shape? If yes, let me measure if the space is enough or not. Ideally, we need almost 15 millimeter space for implant bar over denture. So when we have the patient with only 11 millimeters space, that means we cannot do the implant bar over denture. We have to design like FP1 type bridge. And second important things is smile line and lip line. So does the patient has the low smile line or high smile line? Is it visible? Here we call the transitional line. Prosthodontic should always check for these two things: inter-arch space, is it enough, and transitional line when we start to design. Then communicate with our surgeon to how much bone should be removed or to gain. Otherwise, we'll get very bad aesthetic or strength result if we don't care about these two things. Okay, and Dr. Mish has classified the prosthetic option in 1985. I think everybody maybe know this. Like FP1 means we replace only the crown. FP2 is we missing the crown and root. FP3 means we have to replace the crown, root, and gingiva. Then RP4 means the overdenture supported only with the implants. So that is also fixed type. RP5 is denture supporting both implant and tissue, like attachment, like bow type and locator type for overdenture, so it's a removable one. So we can have cast with the model measurement. We take the bite registration and mount it to the cast to the articulator. Then think about the treatment plan and which type is suitable for the patient. We also could combine our wax-up and model and CT to check the bone volume and arrangement the implant position. We use the computer-aided design, and we can see here the good bone volume may arrange the straight implant, but the atrophy bone may require tilt implant to avoid some sinus or nerve. For the zygoma implants, we find in no bone in the maxilla regions. So here's the chosen protocols. As we can see here, actually we wax up first, then we arrange the implant position second.